Good morning, everyone. I really want to kick off in a moment with Katie. And I met Katie very recently when, with help from colleagues in NHS England, I think Shahana's on the call and listening to this Webex, I asked if people who had lived experience of long-term conditions would co-present with me at a conference. And in fact, I decided to throw away all the slides we prepared and just get Katie and another person with lived experience, Isaac, to just talk about if they had a magic wand, what would they like the system to look like? And I would then respond to it. So I'm a little bit better prepared today, Katie, I can tell you, because I have heard what you said before. But I really wanted people to hear what Katie's lived experience of multi-morbidity is, and also how she would like the system to be designed to meet her needs. So Katie, without any further ado, can I hand over to you now, and if you could wave your magic wand, what would the system look like?
Okay, before I get hold of this magic wand, I'll briefly introduce myself. My name's Katie and I'm 35. I live in Nottingham currently, and for the past 2 decades I've been living with an increasing number of long-term conditions. I have 5 neurological conditions, 2 endocrine conditions and 2 mental health conditions. In addition, the side effects of the conditions and treatment create even more issues. Around this web of conditions and treatment, there's also a web of people. Myself, I see very much at the centre of that web, along with my wife, who is my full-time carer. I also have involvement from the GP, the practice nurse, the practice manager, 5 specialist consultants and 3 allied health professionals. Doing a little bit of tallying up last night, we believe that adds up to about 34 appointments a year, which is 1 every 10 days, or roughly 24 hours of contact with the medical community. And that's without routine blood tests, A&E visits and all of those things that I sign myself up for. To make things slightly more complicated, half of my care is provided in Nottingham, but I also have half of my care at a specialist hospital in Liverpool, which creates travel and other logistical problems. In preparation for today, I wondered who is in the best position to make sense of this web of conditions and people, and I believe there's currently no medical professional place to do that. In fact, best placed are myself and my carer. But I also, before I go into my magic wand, want people to remember that patients aren't just numbers, and we bring our own key skill sets and talents. I'm not just a number of diagnoses. I try to be an active wife, daughter, sister, auntie and friend. I'm a qualified social worker and have undergraduate and postgraduate qualifications in health psychology. I am an experienced health psychology researcher, and ironically my PhD and a national project that I ran were based on the psychological impacts of long-term conditions. Having had to give up my job in child protection social work, I've tried to embrace my patient status, and I have been elected to the Council of Governors of an NHS Foundation Trust, and more recently appointed to the NHS England's People's Panel. Independently, I also blog, vlog and tweet using the username Not Just a Headache in an attempt to raise awareness of the devastating impact of one of my conditions, cluster headaches, and the other trigeminal autonomic cephalalgias that I have. I wondered what to tell you first, whether to tell you about the medical side of me or the personal side of me, and I wonder what you remember about me now, as I often feel when I walk through the hospital doors, the bit about me gets forgotten and left outside. But in order for me to take control of this situation, I believe that I am much in need of this magic wand being offered by Martin. The first thing I would ask for with my magic wand is a care plan, a fit-for-purpose care plan, one that helps make sense of my web of chaos. I want the best possible medical care, but also the best psychological care and social support in order to get as much out of my life as I possibly can. I want mental health care provided by a team who understand what it's like to live with a physical long-term condition. I want it to be my care plan. I want ownership, and I want it to go wherever it goes with me. It needs to be portable. I've seen my medical file, and I can guarantee that I am not carrying that round, and most people are most certainly not going to read it. It needs to be a snapshot, a patient on a page, a starting point for their engagement with me. I also need someone alongside me, someone who has the ability to ensure that this care continues to be coordinated. Because without an email address that ends NHS, I don't believe that I would have that power. I need this care plan to be for all areas of my life. I need it to be holistic. I need it to recognise that my work and my relationships and everything else in my life impacts my health and vice versa. And it also needs to be a lifelong, flexible care plan. It needs to be something that acknowledges that a long-term condition is exactly that. It's here with me for the rest of my life. And as things change in my life and in my health, the care plan needs to adjust alongside. I also, with this magic wand, would like some education and training. In my role as an overviewer of my health, I need some education and training to make me knowledgeable and empowered to live with my diagnoses. Not just biological and medical training, but also how to access care, who are my team, what are their roles, and where and when can I access support that I am offered, and how to find out what support is available. This training needs to be comprehensive and accessible, as well as consistently and routinely offered across the NHS and in all conditions. A period of extra support is essential at the time of diagnosis. Something to do with the orientation of who the staff are, what their roles are, what patient support groups are available, how can I take care of myself and make sure that I'm in the best possible position to be as healthy as possible going forward. Certainly with my Addison's disease diagnosis, I left hospital with just those 2 words, Addison's disease. And believe me, Dr. Google will have you convinced that you are going to die within 5 minutes, and you need some reassurance from somebody who knows all of the systems around you. This training needs to reflect the lifelong journey with long-term conditions and all the new challenges that it can bring along the way. I'm not saying that this doesn't exist right now, and I just quickly want to give you an example of what is working well in my care at the moment, an example of something that isn't working so well. Firstly, something that isn't working so well, there's been a recent change in the appointment system, which sounds quite benign, and whereas previously you would get your next appointment on the day of your clinic visit, you now get only 6 to 8 weeks in advance of the appointment. This sounds slightly irrational, but not having sight of that appointment doesn't work for me. From the day I see my doctor, I'm thinking about how do I cope from this point in time until the next time I see them. How long do I have to cope for? And when I have a bad day, I think, oh, it's okay, I've just got 3 months left till I see him. It brings added insecurities, adds to mental health issues that patients have, and it can affect other parts of your life, and things can start to fall apart a little bit when you don't have that security. Something that does work well, and something that Bev touched upon before in a Twitter conversation came up over the weekend, my consultations with my neurologist, the letters are dictated copying in every other medical person working with me. But of most value to me, these letters are dictated in front of me. He stops to check details with me, and he's thorough and accurate. And he uses my words. So if I feel bloody awful that day, that's what gets written on my letters. He also reflects things in my actual life outside of my condition. So if I've achieved something, for example, what I'm doing right now, or I lose something, like I have a bereavement, or I lose my job, or my benefits are disrupted, then he makes a note of that as well. He sees the entire patient and he records that whole patient experience as well. So those practitioners who aren't quite there yet get to see that when they read my letters and get to understand a bit more about me. So the key messages really I wanted to give you were that I am the expert in me. The medical team who can take care of me are genuine superheroes in my mind, but so am I. They look after me for 24 hours a year, face to face, and I fight 24/7, 365 days a year. This battle and what I learn along the way deserves the respect from medical staff, the NHS, policymakers, and as far as politicians and the government. This is a unique position, and we are in a position here to save the NHS money. If we're better equipped to look after ourselves, then we require less contact with people and take up less appointment times, or we turn up for our appointments and take our medication appropriately. But in order to do all of those things and be the expert in me, I do need that training and support that I ask for. A concise, portable, patient-on-a-page care plan that would allow me to retain some level of control as I navigate different departments, different hospitals and different trusts. And also, finally, there needs to be someone accountable for me, ensuring that my care is coordinated and that achieves the goal of giving me the best possible care, as well as the target of having my life goals acknowledged and the support to both achieve them, but also to move the goalposts a little bit, because as is the journey with long-term illness, things change every day. There you go, Martin.
Katie, thank you very much indeed. I mean, every time I hear you speak, I'm enthralled. I think that Katie has elegantly and eloquently articulated what I have felt for a long time as a clinician is going to be fundamental if we are going to meet the challenges of the 21st century, which is to recognize that the individual with lived experience of their condition is, or conditions, is the most important person in the system, and that empowering and enabling their ability to self-manage and self-care is of critical importance. It was very interesting for me this weekend to read in the British Medical Journal an editorial, a paper about multimorbidity and guideline recommended treatments for people with multimorbidity. And I have put the links to those papers on my Twitter feed, but I'll read you the last paragraph from the editorial, the last couple of sentences from the editorial by Christiane Muth and Paul Glasieu, who are actually from, I think, from Australia and Germany. But they say, we must establish a clear understanding of each patient's circumstances, preferences and treatment goals, along with close follow-up of goal attainment. Only then will patients avoid being left confused and even tyrannized when their clinical management is inappropriately driven by algorithmic protocols, top-down directives and population targets. Quite a strong statement. So this leads me on to, in part, following that powerful statement from the importance of the person, what is the role of the profession, and how can we support the professions in delivering this aim? Well, the first thing is that we have to realize that long-term conditions are now the agenda in the 21st century. Back in 2008, the Compendium for Long-Term Conditions identified 70% of health and social care spend is taken up by long-term conditions. There are 15 million people. 30% of those will have more than one long-term condition, and that combination and that number increases with age and also increases with deprivation. So although age correlates with multimorbidity, it doesn't cause multimorbidity. And we have to remember there are a lot of older people now living very healthily, and we want to encourage that, but some are not living longer and well. And importantly, I think that one of the things that I'm trying to persuade the system to recognize is that we need to move from a system where the principle of the delivery model is based on the condition to a system where the principle is that we are focused on the person and we look at the condition as being important in their lives, but not dominating how we deliver, not being the principle of our delivery model. There is increasing evidence of overtreatment and harm, and that, as Katie described, one day a year is taken up with her encounters with the medical profession, the rest of the time she is utterly and totally dedicated to self-management. And it seems to me that there are a number of priority actions, and we've been putting some thought into what does self-care mean for people. And I think self-care covers a continuum across the life course. So self-care is about keeping ourselves well and healthy, even if we don't have long-term conditions. And we know the power of brief interventions. We've got a new explosion of wearables which can help people maintain health and well-being. But I also think that access to a digital care record is going to become increasingly seen as commonplace. About, I think it's 60% of the population now manage their bank accounts online, and I think having access to your healthcare record is as equally important, if not more important, than having access to your bank account. We know that where people have a single or dominant condition, that there is a need for self-management training and evidence of benefit of that. And also, I think the digital era will enable us to deliver that in a multitude of ways, including and not getting rid of face-to-face support and management, but also, as Katie's so brilliantly described, a digital care plan, so that the information about me is with me wherever I am, and that we don't have professionals scrabbling around, repeating the same questions over and over again, and not knowing what has gone before in supporting people to manage long-term conditions. I think that where we move into people with multiple conditions, the importance and the absolute need for proactive care and support planning, which I think we must stop thinking of as being something which can be built into a routine consultation, and must be seen as an intervention. It must be given the time and space, resource and support to enable it to be done properly. And also we need to change the way that we fund management of long-term conditions. And I think that the introduction of personal health budgets and integrated personalised commissioning and year of care funding, as I've seen around the country, the brilliant changes that that brings for people's lives and also their interactions with professionals cannot be underestimated. And it is another example of how we need to shift the power towards the individual rather than the individual having to fit within the restraints and constraints of the system. And then, of course, one of the things that we know is that we will all die. And being able to have serious illness conversations with people that open the possibility of discussing what matters most to them and what would matter if is incredibly important. So I think we can see a continuum of self-care from how we look after our own health to how we support people to make decisions about end of life, and building more and more control throughout the system for individuals is incredibly important. And I put right in the centre there patient activation measurement, because of course Katie is an example of someone who's highly activated, has great insight, and is of immense benefit to the NHS. But we know that for some people their health literacy is something which they need support to develop. And that actually, I think, is a really important role for the professionals in the 21st century, is how do we coach and support people. So I would encourage everyone to follow up with Penny Newman's webinar, which I know is following on from this in a couple of weeks' time, because I think health coaching and the ability to become coaches and mentors for people with long-term conditions is going to be an increasingly important role for professionals in the 21st century. And that's why we've adopted a framework which is condition neutral. It works no matter what your condition or conditions are. And that is about truly thinking about what do we need to do to empower patients and carers? How do we support professional collaboration so we actually reactivate the original premise of the term given to the specialists, that they become consultants? The responsibility and the locus and focus of control remains in the community, close to home. That we don't have expert generalists who are expected to support specialist needs, but we have specialists who are expected to support the expert generalist needs in the community. And that we draw upon best evidence. Evidence-based medicine, as originally defined by Sackett and Muir-Gray, was the use of evidence to inform the consultation in line with the individual's preferences and values. So evidence should be an enabler, not a driver. And we need to design our commissioning system so it supports continuity of information, continuity of management, and relational continuity. So many of our financial drivers and the measurements we use need to change, and I'm glad to say that within NHS England there is serious attention being paid to that. It will take time, but I feel the shift that we need is beginning to happen. And I think the journey we've been on has realised many of the points that Katie has already made, but it's worth re-emphasising them. That well-being is about more than just medically managing a condition. It is not just about surviving, it is about thriving. It's an ethical, social and financial issue. In fact, we will deliver better value by empowering and involving and engaging people in the care of their own lives. We need to take account of that, and we need to acknowledge, respect and draw upon the fact that no one knows more about their condition than the person who has it. Our declaration came about as a result of a conversation I had with a consultant in Sheffield who runs an adult cystic fibrosis unit, a guy called Martin Wildman. And I think that his unit articulates several key points about long-term condition management. One is that when I was a medical student, there was no such thing as an adult cystic fibrosis unit. The successes of the 20th century have created, I was going to say a headache, but in deference to Katie, I won't, have created some of the problems we now face in the 21st century. His approach is a team approach. It's very much a multidisciplinary team with the patients very much at the center of that team working, with some very simple key performance indicators, relentless quality improvement, relentless measurement of those KPIs, and using them to design the system of care, which has disrupted the way they design their outpatients, but they can do that because they have year of care funding for the people they serve. But as I left his unit, which I thought was one of the joys of this year, visiting that unit and seeing the passion and enthusiasm which they supported empowered patients to have better lives, Martin said to me, if we want to change the way we support individuals with long-term conditions, then the first thing we're going to have to do is change professional behaviour. And that's what our declaration is about. It's about creating a movement among professionals to support person-centred care. It's been co-produced with the Coalition for Collaborative Care, developed with health and care professionals, policymakers and people with lived experience. and to create a real sense of purpose and a vision for the role of professionals in the 21st century as being, as Baz Luhrmann puts it on his YouTube video, guides, not gods. We want people, professionals, to declare their commitment to putting patient-centeredness into their work in a way which actually aligns with the vision of the long-term condition framework. So it's not about the condition, it's about the person. We want to create a two-way dialogue, and we want to hear what people are doing to support person-centered care. And actually, it's incredible the changes that I'm now seeing and hearing about across the country in various different places where people are really grasping the nettle of changing the way their system works to embrace person-centered care. And we want to know how we can help you. And this is about using behavioural change to open minds. So it's about really articulating the problem, the nature of the problem, the need for change, the appreciating the difficulties that people will have in embracing this change, appreciating the fact that we need to change the system drivers and system enablers so that they support person-centered care. It's about sharing case studies and success and appreciating the work that people are doing. We're sending out the newsletter. We have the improvement support that Bev set out at the front of this webinar, and you're participating in this Lunch and Learn, and using social media and building our network of clinical champions to carry professionals with us and to support people in becoming really empowered with their carers and drawing upon the community assets at their disposal to address the biggest challenge the NHS is facing. So we would like you to connect and make a declaration, tell people about our work, spread the word, ask people to give us their feedback, thoughts and ideas, use our hashtag, Agenda for Person-Centered Care. When you see work that's relevant, let us know and email us to tell us about all the good work that's going on out there, because there's far more than I think the centre often appreciates, and we need to make sure it's valued. So really it's now time for us to engage with you over the next 20 minutes about this. I'm sure people will have lots of questions, and I'm here to answer those and to try and provide some support for all of you I know who are out there doing terrifically good work on the front line with people and communities. So over to you.
Thank you, Martin. I have to say that was fabulous from both of you, so well done. You can both have a glass of water now for a few seconds. Katie, before we open up the discussion, I will come back to you just to respond to anything Martin said, if that's helpful. But while you're just catching your breath, both of you, I'll just feed back some of the conversations off Twitter, if that's okay. So collaborative care are saying it's not just about surviving, it's about thriving. Self-management, UK partnership, sorry, are saying I want to be as well as possible even with my multimorbidities, and maybe multimorbidity is a term that needs to be got rid of because it makes people feel ill, just the word itself. Like Katie, I want a care plan too. And Self-Management Partnership are saying they're offering the type of training that Katie and probably others are looking for, so there's a connection to be made there. Collaborative care wrapped, as I think we all were, to be fair, by Katie's story and how she would use her magic wand. Firstly, a portable care plan, so I think that certainly made some real traction around having that, you know, care on a page sort of approach. So that's kind of the first few tweets that we've got coming back during the conversation. Katie, do you want to respond to anything Martin said? Push him a bit harder? Take it a bit further? What were your initial thoughts?
I think my initial thoughts are that everything looks like it is definitely going in the right direction, in the direction I want it to go in. I see the medical side of it, the doctors, the GPs. I see that being a big challenge, getting everybody coordinated and everything linked up. But then you're still missing this gap of the psychological and the social side of things. And Martin mentioned financial and things like that. And it is something that it touches every area of your life as well as every area of your body, if you may. And I like the way things are going in the joined up thinking within the NHS. I'm just not sure if there's other people that need to be part of that joined up thinking as well.
Okay, no, that makes sense. So sorry, go on, Martin.
Can I respond to those important points? There's a couple of three things I think. So I think it is about switching the emphasis in the system to what matters most to you. And I think Katie Granger has demonstrated to us all the power of social media in changing people's attitudes. So the "Hello, my name is" campaign was thrilling to watch. I think that Atul Gawande has set about, with his great book Being Mortal, reframing the proposition for modern medicine to exactly this agenda: what matters most to you? And then bringing the professional expertise and knowledge into that conversation, not starting with the professional expertise about, I think this is what matters most to you and you should do what I say. I think the second point that Katie made was around psychological. And I couldn't agree more, and sorry if I didn't emphasize that enough, but it is about taking as Juvenal said over 2,000 years ago, it is about having a healthy mind in a healthy body. And he started with the mind. If you look at the word itself, dis-ease is about not feeling at ease with yourself. And we know from studies and work we've been doing, for instance, if you have anxiety and depression in association with a physical problem, it increases your utilization of healthcare resources. So not only is it beneficial to the individual to address psychological issues and provide psychological support, but it makes economic sense as well. And then in the joined upness, I think that we have to embrace the fact in a digital era, I've spent 20 or 30 years trying to pass bits of paper around the system. We are moving at a speed and a pace which means that the only way we can do communication now is digitally. When I was a surgeon, my patients who came for gallbladder removal would stay in, I thought I was really good because they only stayed in hospital 5 days. That operation is now done as a day case. Lengths of stay in hospital have shrunk enormously. People are in and out really, really quickly. And unless we embrace digital healthcare records, I think we will never keep pace with the nature of the environment we're operating in. And the one thing about a digital healthcare record, especially if it's owned by the individual to whom it matters most to, is it can help join up the system really effectively. So that would be my response to Katie's challenge, which I think, she's put a finger on the nub of the issues that we need to address.
Brilliant. Okay, well, we'll keep this conversation going, but I'm going to try and bring a few other people in now. So, Christine Morgan, can we bring you in? Would you like to just introduce yourself and then pose your thoughts that you've put into the chat box? Okay.
Oh, hi. Yeah, thanks for the opportunity. Yes, really enjoyed this morning, and both listening to Katie and Martin, and particularly identify with Katie. And I'd say one of my frustrations is that I realised a long time ago that I was the only person that was actually coordinating anything, that knew sort of the whole of everything that went on. So I've kept my own record for decades now, and I offer, often if I'm going, if I've got a referral, I offer a summary to the professional with all the kind of stuff that I know they're going to ask me. So I just print it out and have it ready. But actually not everybody wants that. They're not really interested in that. And I feel this is where you do need the partnership. I don't know what's of clinical interest to them, but certainly I find when I go on appointments, most professionals, however good they are, and a lot of them are, you know, really great, they don't actually want to know about any of the other conditions. They only want to know about the presenting feature in front of them. So I think Katie's idea of a single profile that actually takes the whole is a great idea, but I think there's a lot of work to do with professionals. Even thinking online, I picked up on Twitter that yes, there is patient online and you should be able to have your summary record, but actually it might be nationally available, but a lot of GPs haven't even told their patients about that. I still can't get access to my summary care record, which I know should have been organised by the end of March 2015. I'm nudging hard. I chair my own, I've just taken on the chair of my local PPG, and I'm trying hard, but finding it quite an uphill battle. So obviously there are, you know, there's some trepidation there with professionals, and I can understand the workload issues, but those are just some of my frustrations, and I'm not quite sure how and where you tackle those.
So that's a really, really important point. So some of you may have read or heard about patient activation measurement. I mentioned it in my presentation. But we also have something called a questionnaire, which is clinician support for patient activation measurement. So we can actually hold a mirror up to people, because often we hear from clinicians, oh yes, I'm very person-centered. But actually, if you get below the surface into the below the behaviours, the attitudes, mindsets and beliefs, there's some quite deep-rooted attitudes and beliefs about the information that individuals should have about themselves. And so this is why I really believe that there is quite a lot of work to do with the profession, to support the profession, because I think there's a really exciting role for professionals in supporting people with long-term conditions, but it's not the one we had in the 20th century. It's a new role about being a guide, a coach, a mentor, and to help people to thrive despite having long-term conditions. And you know, this isn't easy, but also by changing what we measure and making patient or individual feedback as important as biometric markers in the system, that will help change attitudes and behaviours as well.
Thank you. Shahana, I think you were going to pose a challenge.
Shahana, it's hi Bev, it's Shahana Ramsden here. Once again, I want to thank you, both speakers. I thought, Katie, you're amazing. I'm so glad I had a chance to hear you speak because I missed you at the last conference. And Martin, thanks a lot for your introduction. I guess my question is, it's so inspiring to be involved in initiatives such as our declaration, the work around health coaching, and it's good to see the language of empowering patients. However, I speak to patients on a day-to-day basis through the co-production group, and the reality of their experience, there's such a gap between the reality of what they experience and the policies and declarations that we're producing. So I guess the question for me is, what else needs to happen now to make sure that GPs on the ground on a day-to-day basis are hearing some of this stuff and actually putting it into practice? That's my question.
Shana, a really great challenge, and it's why I've thought about, this is getting a bit techie, but what are the drivers, what's the principle of a delivery model, what are the enablers? And for me, there are four big drivers, so politics, policy, measurement and money. And I think the politics and policy are lining up behind this. but I don't think the measurement and money have changed in a way which make it desirable and easy for professionals to take a person-centered approach. And so there's quite a lot of work going on to try and change some of those. So people, organisations, systems move in the direction of the questions asked of them. And what we measure is one of the most important questions. So for instance, do people have care plans that they have access to? Are they used by professionals? Do we measure patient activation? Do we measure the degree to which people feel involved in their care? And there are measures and metrics coming out. But also I'll go back to something I said in my presentation. We have to understand that care and support planning, doing this, is not something which can be shoehorned into a routine consultation. And I do believe that we need to, it was Pete Kirkbride, a colleague of mine who's actually an oncologist, who said, we need to see this as an intervention, not just something that you do in business as usual. A bit like doing an operation or a lumbar puncture or something like that. We need to create the time and wherewithal for people to be able to do that. And that's something which I'm arguing very strongly for inside NHS England. And I believe, although I'm somewhat perhaps out on a limb myself, that we need to stop asking for some things that we're asking for at the moment to create the space and time for professionals, especially in the community, to be able to do this work properly.
It's a conversation that will keep growing and growing, and I think Nick wants to just comment on that and ask a separate question directly to Katie. So Nick, are you there? Put you his comments, Martin, if that's all right, just because it links to what you've just been saying, so I didn't want to lead back to it later. But it says, what does Martin think we as patients can do to challenge the attitudes in the healthcare professionals we meet?
So I think it is about being appreciatively assertive. I think it's about, you almost, some of you guys who are on this call, I'm sure, will be able to do this quite well. I think you need to coach professionals to help you. So it's about bringing them on the journey with you to see that actually this doesn't threaten them. You're not here to disempower them, but actually to help them collaborate with you to do what actually I believe in their hearts, one of their values will be to deliver great care. It's about saying, look, I think it would, you know, we use the word challenge, and that's quite confrontational. And I think it's about coaching professionals to see that there are opportunities and there's potential for them by engaging and empowering you as an individual. So why don't you work with me? It'd be lovely to work with you to let me have access to my healthcare records, because I want to see how I can help you with my own care. I used to have my computer screen turned towards the person when I was consulting as a GP, which my partners were horrified at. They said, you might put the wrong notes up. And I said, well, that would be lucky, because that would mean then I'd get the right notes up. Or they might spot that you put something wrong in the notes. And I said, well, that'd be great, then we can correct it together. And I think there's an underlying fear of an adversarial opportunity to be taken. And if we approach this in a collaborative, appreciative way, I think we'll start to disarm some of the professional fears. So it's about understanding the fears that drive professionals. Oh, people will sue me. People will see I've made a mistake and will take action. People won't understand what's there, and it will increase the length of time I have to consult with them. But actually, if you look at the process for care and support planning, it takes care of some of those fears and addresses some of them purposefully. So I think we've got a journey to go on, but we need to go on it together. I hope
Brilliant,
that helps.
thank you. So just, Nick, if you can pop a message into the chat box, excuse me, and we can just check that out. In the meantime, I'll just give you a rest for a second, Martin, and turn back to Katie with some, if I can just read this out. So one of the challenges Nick's here is related to portable patient-owned care plans. Is the patient's readiness to own or access clinical documentation, presumably warts and all sometimes. I'd be interested to hear Katie's views on what rules would govern it, i.e. if you don't like a particular assessment finding or recommendation, can you remove, exclude, hide it from the record, etc. Katie, do you have any immediate thoughts on that?
I think that lines up with what I was saying about needing somebody alongside me to manage my care plan. I want to be able to have sight of it, and I want to see all of it, warts and all, but I need somebody there who has got a more a more rounded view of the situation, somebody who's a medical professional who can say, well, no, that really does need to stay in there because it's important. It might be something that you don't want to see, but it needs to be there. Or if I need amending because I don't think it's been written properly. I mean, as an ex-social worker, I've sat and done that with clients and sat and changed the wording, because sometimes it's as simple as that. It's as simple as the wording on the page. But I do think that as much as I want ownership, I do think it needs to be done with somebody else.
Brilliant, thank you. Just to correct some of them, I'm crediting Nick, but it was actually Lynn who's asked them. So Lynn's going to go and talk to her GP now. If I can just interpret this question right, then Martin, I think this one's back to you, is just around this plan on a page or this portable care plan. To what extent is establishing a consensus on the parameters a barrier to near-term implementation?
I don't think it is. So I think this is a journey of familiarity. So I think the promised land is a fully shared care plan, which both, in my belief, both patients or individuals and professionals can contribute to. And I think we're some way from that yet. But I think that the first step is simply to make visible what we've got now. And so, for instance, Amir Hanan's practice in Hyde, I think he must be getting on for nearly 30% of his patients now have access to their own care record. And a very large majority of those are people with long-term conditions. So I think when I last spoke to him, 60% of his patients with long-term conditions had access to their own health record. But that's a read-only. And they can share it with other people because they have access to it. But already it's transforming the way that people interact with the health system and the way that professionals interact with them. And I think as we go, step by step, the first step is let's use what we've got now. And the summary care record, as of this month, allows us, with the individual's permission, to switch on visibility of their care plan. The summary care record at the moment is very high level and quite limited, but still useful. But it now has the potential to switch on a lot more information with the individual's permission. And I think as both professionals and the population become more familiar with managing their own, managing, sharing digital healthcare records, it will become more interactive, much less just a record, but an interactive platform for people to use to manage their lives really much more effectively. If I think about the way that the last few years, how I've moved beyond just sort of looking at my bank account to actually managing my bank account, I think we're on a, the analogy is not exact, but it's not dissimilar for healthcare records. I hope that makes sense, but if anyone's got a query about that, happy to take a question. Oh, running out of time, actually.
Okay, brilliant. I know. We've got. I'm just going to let Lily Sharma make a comment about something she's put in the chat box, because I think this will be actually quite interesting and important. And then we'll come back, Martin and Katie. Katie, you will have the last word this time. But we'll come back to both of you just to say what's the one thing that you would like people to do when they leave this call. So, what's the first step that they need to make as soon as they go away. So we'll come back to you on that. But firstly, Lily, can we speak to you?
Hi, can you hear me?
Yeah, perfect, Lily, welcome.
Yeah, I just wanted to say that Martin mentioned activation, clinician support for patient activation measure. So NHS England, we did a survey last year for about nearly 1,750 clinicians, which included doctors, nurses, and allied health professionals. And we've got a report now, which we will be publishing very soon. So that, it helps us to understand the views and attitudes of clinicians and the kind of things they're doing. They say they're doing practice. Some of the barriers they report towards, the delivery of person-centered care, and the different kind of barriers where they say which they face. So that report is going to be published very soon. So I'd encourage people to see that. We'll be sharing it widely with different audiences, and that will be available on the NHS England website as well, along with the Health Foundation and lots of other places. So
fantastically, I think the work you've been doing on this has been of enormous value, and I think it all adds to the momentum for change. So thank you very much.
Thank you, Martin.
Brilliant. And adds to that comment about maybe changing roles to a guide, a coach, and a mentor. So I think that's all helps with that. Okay, so we are a little over time now, but I think it was well worth it. It's been a fabulous discussion, and thank you very much to our two speakers, Martin and Katie. It's an important subject and not one we're going to solve in an hour, so let's keep the conversation going either on Twitter or by email, or just hearing how you're getting on. Lynn, it'd be great to hear how you coach your professionals to a different relationship. So keep communicating with us. I think this, change takes time. It's not going to happen overnight, but let's keep moving forward. So on that point, I'm going to move back to our speakers. So Martin first, and then Katie. What's the one or two things that people can do when they leave this call?
So what I would like people is to participate in our declaration, but also just feel emboldened and determined to keep pressing on. It will take time. This is a massive mindset change within the professions. It requires significant change within the system. But what we know is that the change in outcomes and quality of life for people that this brings and can bring is worth the effort. And thank you all very much for participating today. And I'm going to leave the last word to Katie because it's the most important word. Thank you very much, everyone.
I agree with Martin. It's definitely a lot of significant change, but I would also like to acknowledge that there is really positive practice out there, and there are doctors and other professionals who are really working in a patient-centered way, and I think we need to acknowledge that, and the more that that is acknowledged and rewarded and promoted, the more things will change within the whole organisation. I think we need to encourage the sharing of positive language and new behaviours, whether that's events like this or Twitter or conversations in staff rooms. It just needs to be promoted. It needs to be constantly talked about in order for these big changes to become a reality for patients like me.
Brilliant. Thank you, Katie. We will ensure the recording from today and the slides are available with you as soon as possible. But leaving Katie's words in your ears, I'd like to call this Webex to a close and wish you all a good afternoon, and let's start making that change now. Thank you, everybody.